What if I told you that the blood pressure target your doctor is pushing you toward could actually be killing you? What if the number that's supposed to protect your heart is actually damaging your brain? What if everything you've been told about blood pressure in your 60s, 70s, and 80s is based on studies done on 40-year-olds? I'm Dr. Olivia, and I've spent 18 years treating cardiovascular disease. I've managed blood pressure in thousands of patients. And I'm going to tell you something that most doctors won't admit. The blood pressure guidelines for seniors are a mess. They've changed repeatedly. They contradict each other, and depending on which expert you ask, you'll get completely different answers about what your blood pressure should be. Some say 120 is the magic number for everyone. Others say 140 is fine for older adults. Some say aggressive treatment saves lives. Others say aggressive treatment causes falls, fainting, kidney failure, and cognitive decline. Who's right? Today, I'm going to cut through the confusion. I'm going to explain the actual science. I'm going to show you the studies, the data, the evidence. And by the end of this video, you'll understand exactly what blood pressure target is, right for your situation, because here's the truth that nobody wants to tell you. There is no single best blood pressure for all seniors. The optimal target depends on your age, your health status, your existing conditions, and your personal goals. One size does not fit all, and the doctor who treats every 75-year-old the same way is the doctor who's going to harm some of them. Let's start with the basics, understanding blood pressure numbers. Blood pressure is measured in two numbers. The top number is systolic pressure. This is the pressure in your arteries when your heart beats, when it's actively pumping blood. The bottom number is diastolic pressure. This is the pressure between beats when your heart is resting and refilling. When I say your blood pressure is 130 over 80, I mean your systolic is 130 millimeters of mercury and your diastolic is 80. For most of the 20th century, we focused on diastolic pressure. We thought the bottom number was what mattered. A diastolic over 90 was considered high blood pressure. But research in the 1990s and 2000s changed that understanding. We learned that in older adults, systolic pressure is actually more important. It's a better predictor of heart attacks, strokes, and death. This makes sense when you understand what happens to arteries as we age. Young arteries are elastic. They stretch when blood pumps through them. They absorb the pressure. They're flexible like rubber bands. But as we age, arteries stiffen. They become rigid. They lose their elasticity. They can't absorb the pressure anymore. When the heart pumps blood into stiff arteries, the pressure spikes higher. Systolic pressure rises. Meanwhile, because the arteries can't recoil properly, diastolic pressure often drops. This is why many seniors have what we call isolated systolic hypertension. High systolic, normal, or low diastolic. A reading like 160 over 70. And this is where the confusion begins. The moving target. How guidelines have changed. Let me take you through the history of blood pressure guidelines because it's important to understand how we got here. In the 1970s and 1980s, high blood pressure was defined as anything over 160 systolic or 95 diastolic. If you were 140 over 85, you were considered normal. No treatment needed. In 1997, the guidelines changed. The new cutoff was 140 over 90. Suddenly, millions of people who were previously normal were now hypertensive. They needed medication. In 2003, a new category was created. Pre-hypertension. If your systolic was between 120 and 139, you weren't hypertensive, but you weren't normal either. You needed lifestyle modification, maybe medication. In 2014, there was a controversial twist. A panel of experts raised the threshold for seniors. They said that for adults over 60, high blood pressure shouldn't be diagnosed until systolic reached 150. A 75-year-old with blood pressure of 145 over 85 was now considered normal. No treatment needed. Many doctors disagreed. Many organizations rejected this recommendation. Then in 2017, everything changed again. The American College of Cardiology and the American Heart Association released new guidelines. They lowered the threshold to 130 over 80 for everyone, including seniors. Overnight, nearly half of American adults became hypertensive. Tens of millions of people who went to bed with normal blood pressure woke up with high blood pressure. And for seniors, the recommendation became aggressive. Get systolic below 130 for everyone. regardless of age. This recommendation was based largely on one study, the SPRINT trial. And this is where the controversy explodes. The SPRINT trial, revolutionary or reckless? SPRINT stands for Systolic Blood Pressure Intervention Trial. It was a massive study, over 9,000 participants, adults over 50 with high blood pressure and at least one cardiovascular risk factor. Participants were randomized into two groups. The standard treatment group aimed for a systolic pressure below 140. The intensive treatment group aimed for a systolic pressure below 120. The study was supposed to run for 5 years, but it was stopped early after just over 3 years. Why? Because the results were so dramatic. The intensive treatment group had a 25% lower risk of cardiovascular events, heart attacks, strokes, heart failure. They had a 27% lower risk of death from any cause. The researchers concluded that aggressive treatment saves lives. Get blood pressure below 120, the lower the better. The medical community was electrified. Guidelines were rewritten. Doctors were told to push patients to lower and lower numbers. But here's what didn't make headlines: the problems with SPRINT. First problem, how blood pressure was measured. In SPRINT, blood pressure wasn't measured the way it's measured in your doctor's office. Participants sat quietly in a room alone for 5 minutes. Then, an automated device took 3 readings with no one else present. The readings were averaged, as this is not how blood pressure is measured in the real world. In your doctor's office, you're often rushed. You've been sitting in the waiting room. Maybe you're anxious. The doctor or nurse takes a single reading while talking to you. Maybe they use a cuff that doesn't fit properly. Studies show that office blood pressure readings are typically 10 to 15 points higher than the SPRINT method. Sometimes 20 points higher? What does this mean? A SPRINT reading of 120 might correspond to an office reading of 135 or 140. A SPRINT reading of 140 might correspond to an office reading of 155. So when the guidelines say get below 130 based on SPRINT, what does that actually mean in a normal doctor's office? Nobody knows exactly. The translation is unclear. Many patients have been pushed to dangerously low blood pressures because their doctors are targeting numbers that don't apply to real-world measurements. Second problem, the side effects. Yes, the intensive treatment group had fewer heart attacks and strokes, but they also had significantly more adverse events. Acute kidney injury increased by 66% in the intensive group. Electrolyte abnormalities, potentially dangerous drops in sodium and potassium, increased by 35%. Hypotension, blood pressure dropping too low, increased by 67%. Fainting increased by 33%. These aren't minor inconveniences. For a 75-year-old, a fainting episode can mean a fall. A fall can mean a hip fracture. A hip fracture in a senior has a mortality rate of 20 to 30% within a year. The study saved lives through fewer heart attacks. But did it cost lives through falls and kidney failure? That's harder to measure. That's not always captured in the data. Third problem, who was excluded? SPRINT excluded people with diabetes. It excluded people who had already had a stroke. It excluded people living in nursing homes. It excluded people with dementia or cognitive impairment. In other words, it excluded many of the most vulnerable seniors, the people for whom aggressive blood pressure lowering might be most dangerous. And yet the guidelines based on SPRINT are applied to everyone, including the people who weren't in the study. Fourth problem, the age subgroup. SPRINT included about 2,600 participants over age 75. And yes, even in this older subgroup, intensive treatment showed benefits. But look closer at the data. The absolute risk reduction was small. About 1.5% fewer cardiovascular events over 3 years. And the harms were higher in older participants. More falls, more fainting, more kidney problems. Was the trade-off worth it? For some seniors, absolutely. For others, maybe not. The J-curve phenomenon. Here's something that doesn't get enough attention. When you plot cardiovascular outcomes against blood pressure, you don't get a straight line showing that lower is always better. You get a J-shaped curve. Yes, high blood pressure is dangerous. That's the right side of the J. Risk goes up as pressure goes up. But at the bottom of the J, around 130 to 140 systolic, risk is lowest. And then something concerning happens. As blood pressure drops below 120, risk starts to rise again. That's the left side of the J. Why would lower blood pressure be harmful? Several reasons. First, blood flow to organs. Your kidneys, your brain, your heart itself all need adequate blood flow. This blood flow is driven by pressure. If pressure drops too low, these organs don't get enough blood. They suffer. Second, diastolic pressure matters for the heart. Your coronary arteries, the vessels that feed your heart muscle, fill during diastole, when the heart is relaxing. If diastolic pressure is too low, blood flow to the heart muscle decreases. This can cause ischemia, lack of oxygen to the heart. Third, the brain is exquisitely sensitive to blood pressure. Studies have shown that aggressive blood pressure lowering in older adults can accelerate cognitive decline. White matter lesions, small areas of brain damage, increase when blood pressure is pushed too low. This is the cruel irony. The aggressive treatment meant to prevent strokes might be causing a different kind of brain damage. What happens when blood pressure is too low? Let me describe what I've seen clinically. Because the numbers on paper don't capture the human reality, I had a patient named Harold. He was 78 years old. His blood pressure had been running around 150/85 for years. His previous doctor had accepted this. He was on one blood pressure medication. Then Harold got a new doctor, a young physician who followed the latest guidelines. She was determined to get Harold's blood pressure below 130. She added a second medication, then a third, then a fourth. Harold's blood pressure dropped to 118/65. His doctor was thrilled. Mission accomplished. But Harold felt terrible. He was dizzy every time he stood up. He had to grab furniture to steady himself. He stopped going for his morning walks because he was afraid of falling. One day he stood up from a chair too quickly. His blood pressure dropped. He fainted. He fell and fractured his hip. Surgery, hospitalization. Pneumonia is a complication. 6 weeks in a rehabilitation facility. He never fully recovered his independence. Harold's blood pressure was perfect according to the guidelines, but the guidelines nearly killed him. This is what I mean when I say one size does not fit all. Harold's body had adapted to higher blood pressure over decades. His brain was used to it. His kidneys were used to it. When we forced his pressure down too quickly, too aggressively, his organs couldn't cope. The other side, when high blood pressure is dangerous. Now, I don't want to leave you thinking high blood pressure doesn't matter. It absolutely does, especially in seniors. Uncontrolled high blood pressure is the single biggest risk factor for stroke. And stroke is devastating. It can leave you paralyzed, unable to speak, dependent on others for every aspect of daily life. Many seniors fear stroke more than death. High blood pressure damages the heart. It forces the heart to pump against increased resistance. The heart muscle thickens. It becomes stiff. Heart failure develops. You become short of breath. You can't climb stairs. You can't walk across a room. High blood pressure damages the kidneys. Year after year of elevated pressure destroys the delicate filtering units. Kidney function declines. Eventually, you need dialysis. High blood pressure damages the brain, not just through strokes, but through small vessel disease. Tiny blood vessels in the brain are injured. This causes vascular cognitive impairment, memory problems, thinking problems, a type of dementia. So, yes, high blood pressure needs to be treated. The question is how aggressively? What's the target? What's the right balance between protecting organs from high pressure and protecting them from low pressure? The real answer, it depends. I know you want a number. You want me to say your blood pressure should be exactly this. But the honest answer is that the optimal blood pressure for a senior depends on multiple factors. Factor 1, your age. A healthy 65-year-old and a frail 85-year-old should not have the same blood pressure target. At 65, you likely have decades of life ahead. The long-term damage from elevated blood pressure is a real concern. More aggressive treatment makes sense. At 85, the calculation changes. Life expectancy is shorter. The benefits of aggressive treatment may not have time to materialize. But the harms, falls, kidney damage, cognitive effects happen quickly. Research supports this. Studies in the very elderly, those over 80, show that blood pressure between 140 and 150 systolic is often associated with the best outcomes. Lower isn't always better. Factor 2, your functional status. Are you independent, active, walking miles every day, living your life fully, or are you frail, dependent on others, limited mobility, multiple chronic conditions? For robust, independent seniors, more aggressive blood pressure control can extend years of healthy life. The body can handle lower pressures. The benefits outweigh the risks. For frail seniors, aggressive treatment is often harmful. Falls become more dangerous. The body can't adapt to lower pressures. Quality of life suffers. A practical test. Can you stand up from a chair without using your arms? Can you walk at a brisk pace? Can you climb a flight of stairs without stopping? If yes, you're likely robust enough for tighter blood pressure control. If no, more relaxed targets might be safer. Factor 3, your symptoms. This seems obvious, but it's often ignored. If blood pressure medication is making you feel terrible, that matters. Dizziness when standing, fatigue, weakness, confusion. These are signs that your blood pressure may be too low. Some doctors dismiss these symptoms. They say the numbers are what matter. The guidelines say below 130, so we're staying below 130, regardless of how you feel. This is wrong. Your quality of life matters. How you feel matters. If you can't enjoy your life because you're dizzy and exhausted, what's the point of living longer? Good blood pressure management requires listening to the patient. If medication is causing significant side effects, the target needs to be reconsidered. Factor 4, your other conditions. Certain conditions affect blood pressure targets. If you have diabetes, blood pressure control is especially important. Diabetes damages blood vessels. High blood pressure accelerates that damage. Tighter control is usually warranted, though even here, too low can cause problems. If you have kidney disease, the calculus is complex. Blood pressure control protects kidneys, but blood pressure that's too low can also harm kidneys. Close monitoring is essential. This monitoring is, if you have coronary artery disease, diastolic pressure matters. You need adequate diastolic pressure to perfuse your coronary arteries. Pushing systolic too low often drops diastolic dangerously. If you've had a stroke, preventing another stroke is critical. Blood pressure control is important. But in the immediate aftermath of a stroke, blood pressure is often allowed to run higher to maintain blood flow to the brain. If you have dementia or cognitive impairment, aggressive blood pressure lowering may accelerate decline. The brain is already compromised. It needs adequate perfusion. More relaxed targets are often appropriate. Factor 5, your personal goals. This is perhaps the most important factor and the one most often ignored. What do you want from your medical care? Some seniors prioritize longevity above all else. They want to live as long as possible. They're willing to accept side effects and multiple medications to reduce their risk. Other seniors prioritize quality of life. They want to feel good today. They want to remain active and independent. They're less concerned about a slightly higher risk of heart attack in 10 years. Both perspectives are valid. Neither is wrong. But the blood pressure target should reflect these goals. If longevity is your priority, more aggressive control makes sense. Accept that you might feel slightly worse. Accept the need for multiple medications. If quality of life is your priority, more relaxed targets might be appropriate. You might live slightly less long, but you'll feel better during the years you have. This is a conversation you should have with your doctor. And any doctor who dismisses your goals, who tells you the guidelines are the guidelines and that's that, is not serving you well. My recommendations, based on the evidence, based on my clinical experience, here's what I recommend for older adults. For adults 65 to 74 who are generally healthy, a systolic target of 130 or slightly below is reasonable. This is consistent with the research. At this age, you likely have many years ahead. Protecting your arteries matters, but monitor for side effects. If you're dizzy, if you're falling, if you're exhausted, the target is too low. Raise it. Don't obsess over the exact number. A systolic of 132 is not meaningfully different from 128. The goal is the range, not a precise point. For adults 75 to 84 who are reasonably healthy, a systolic target of 130 to 140 is often appropriate. You might benefit from the lower end if you're robust and tolerating medication well, but be cautious. Fall risk increases with age. Kidney function often declines. The margin for error is smaller. If you're on more than 3 blood pressure medications and still not at target, question whether the target is right for you. Multiple medications mean multiple side effects and multiple interactions. For adults 85 and older, a systolic target of 140 to 50 is often reasonable. The very elderly are at highest risk for harm from aggressive treatment. Studies in this age group show that blood pressure in this range is associated with good outcomes. Lower is not necessarily better. Prioritize how you feel. Prioritize your independence. Prioritize avoiding falls. For frail seniors at any age, frailty changes everything. If you're frail, if you have multiple chronic conditions, if you're dependent on others for daily activities, aggressive blood pressure control is often harmful. A systolic of 140 to 150 may be appropriate. Sometimes higher is acceptable if attempts to lower pressure cause problems. The goal is to prevent catastrophic events like stroke while maintaining quality of life. This requires individualization, not blind adherence to guidelines. Practical steps you should take. First, know your numbers. Buy a home blood pressure monitor. They're inexpensive, usually $30 to $50. Measure your blood pressure regularly at the same time each day after sitting quietly for 5 minutes. Keep a log, show it to your doctor. Home readings are more reliable than office readings. They show what your blood pressure actually is in your daily life. Second, check for orthostatic hypotension. This is a drop in blood pressure when you stand up. It's common in seniors, especially those on blood pressure medication. Here's how to check. Sit quietly for 5 minutes. Measure your blood pressure. Then stand up and immediately measure again. Wait 3 minutes and measure a third time. If your systolic drops more than 20 points or your diastolic drops more than 10 points upon standing, you have orthostatic hypotension. This means your blood pressure is probably too low. You're at risk for falls. Tell your doctor. Third, review your medications. Many seniors are on blood pressure medications that were started years ago under different circumstances. Sometimes they're no longer needed. Sometimes the doses are too high. Ask your doctor, do I still need all these medications? Can we reduce any doses? What would happen if we stopped one? This is especially important if you're on 4 or more blood pressure medications. That's usually too many. Something is wrong with the approach. Fourth, address lifestyle factors. Before adding more medication, make sure you've addressed the basics. Reduce sodium intake. Excess salt raises blood pressure. Aim for less than 2,300 milligrams per day. Less than 1,500 if you're salt sensitive. Maintain a healthy weight. Excess weight raises blood pressure. Losing even 10 pounds can make a meaningful difference. Exercise regularly. Physical activity lowers blood pressure. Even walking for 30 minutes most days helps. Limit alcohol. More than 1 drink per day for women or 2 for men can raise blood pressure. Manage stress. Chronic stress elevates blood pressure. Find healthy ways to cope. These interventions won't replace medication if you have significant hypertension, but they can reduce the amount of medication you need. They can help you achieve targets with fewer drugs. Fifth, have an honest conversation with your doctor. Tell them your goals. Tell them your concerns. Ask questions. What's my blood pressure target? Why did you choose that number? What are the risks of this target? What are the risks of a higher target? How will we monitor for side effects? What happens if I don't tolerate the medications? A good doctor will welcome these questions. They'll explain their reasoning. They'll adjust the plan based on your input. A doctor who dismisses your concerns, who says just follow the guidelines, is not providing good care. Consider finding a different doctor. Special situations. Let me address some specific scenarios that many seniors face. If you've been recently diagnosed with high blood pressure, don't panic. High blood pressure is common and treatable, but make sure the diagnosis is accurate. Demand multiple readings over multiple visits before starting medication. A single high reading doesn't mean you have hypertension. Consider ambulatory blood pressure monitoring. This involves wearing a device for 24 hours that takes readings every 15 to 30 minutes. It gives the most accurate picture of your blood pressure. White coat hypertension, where blood pressure is high only in the doctor's office, is common. Up to 30% of people diagnosed with hypertension actually have white coat effect. They don't need medication. If you're having side effects from medication, tell your doctor immediately. Don't suffer in silence. Don't assume this is just how it has to be. Side effects are often fixable. Sometimes a different medication works better. Sometimes a lower dose is sufficient. Sometimes stopping one of several medications helps. Common side effects include dizziness, fatigue, frequent urination, dry cough with ACE inhibitors, ankle swelling with calcium channel blockers, and sexual dysfunction with beta blockers and some diuretics. You don't have to accept these. Speak up. If you've fallen or had a near fall, this is a red flag. Falls in seniors are often related to blood pressure medication. Check for orthostatic hypotension, as I described earlier. Review your medications with your doctor. Consider whether your blood pressure target is too aggressive. A fall resulting in a hip fracture can change your life forever. Preventing falls is just as important as preventing strokes. If you have wide swings in blood pressure, some seniors have blood pressure that varies wildly. High in the morning, low at night, high one day, normal the next. This variability is itself a risk factor. It suggests unstable blood vessel function. It can be challenging to treat. Don't chase every high reading with more medication. You'll end up overtreated. The lows will become dangerous. Work with your doctor to find medication that smooths out the variability without pushing average pressure too low. The bottom line. Let me summarize what I want you to remember. Blood pressure matters. High blood pressure causes strokes, heart attacks, kidney failure, and cognitive decline. It needs to be treated. But treatment must be individualized. The 130 target that's right for a healthy 65-year-old might be wrong for a frail 82-year-old. Lower is not always better. There's a J curve. Blood pressure that's too low causes its own problems. Falls, fainting, kidney damage, cognitive decline. Age matters. Older seniors generally need more relaxed targets than younger seniors. Frailty matters. Frail seniors need more relaxed targets than robust seniors. Symptoms matter. If you feel terrible on your current regimen, the target may be too aggressive. Your goals matter. Some people prioritize longevity, others prioritize quality of life. Both are valid. Your treatment should reflect your goals. Guidelines are just guidelines. They're population-level recommendations. They don't account for individual variation. A good doctor uses guidelines as a starting point, then adjusts based on the patient in front of them. You are your own best advocate. Know your numbers. Monitor at home. Watch for side effects. Ask questions. Speak up when something isn't working. This is your body. This is your life. Take control of it. What you should do. Next, I want you to take 3 actions after watching this video. First, buy a home blood pressure monitor if you don't already have one. Start tracking your numbers. Knowledge is power. Second, schedule an appointment with your doctor specifically to discuss blood pressure. Not a rushed visit where blood pressure is one of 10 things on the agenda. A focused visit where you can have a real conversation. Third, share this video with a friend or family member who has high blood pressure. The information I've shared could save their life. If you found this video valuable, please subscribe to this channel. Hit the notification bell so you don't miss future content. Leave a comment below. Tell me your blood pressure numbers. Tell me what target your doctor has given you. Tell me if you have side effects from your medication. I read every comment and I'll try to respond. And remember what I told you at the beginning. There is no single best blood pressure for all seniors. The optimal target is the one that protects your organs while preserving your quality of life. Work with your doctor to find that target. Don't accept a one-size-fits-all approach. Demand individualized care. Your heart, your brain, your kidneys, your life, they're worth it. I'm Dr. Olivia. Take care of your blood pressure, but do it wisely. I'll see you in the next video.